Perioperative management of a parturient with a cardiomyopathy. If you look at the incidence of cardiac disease as per the CMACE 2006 to 2008, the latest published report, the incidence of cardiac disease, as Dr. Chan had pointed out, has remained constant over the decades at 1%. It has not changed, and it is the leading cause of indirect maternal deaths. And if you look at cardiomyopathy, they are a group of very rare but fatal diseases. And in the report, the CMACE report, 13 patients actually died of cardiomyopathy. But what is more disturbing is, in 7 out of these 13 patients, the care was deemed to be substandard in terms of diagnosis or in terms of investigations and appropriate referral. So that is what is most disturbing, because this is something which can work on and prevent. This is mortality which can be prevented. And to prevent mortality, we have to understand the pathophysiology of the disease so we can have a good perioperative management. Basically, cardiomyopathy is of 6 types. We can have a hypertrophic obstructive cardiomyopathy, a dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, left ventricular non-compaction cardiomyopathy, restrictive cardiomyopathy, and peripartum cardiomyopathy. I'm not going to dwell into the things which I've marked in yellow because they are very, very rare. What is more common is hypertrophic obstructive cardiomyopathy. That's one of the commonest cardiomyopathies. But if you take into account a parturient, what is more common is probably a peripartum cardiomyopathy, because if you see the prevalence, the geographical distribution of peripartum cardiomyopathy varies, and in places like Haiti, it's about for 1 in 300 deliveries. So you see that the incidence of peripartum cardiomyopathy is quite high. What about statistics from India? I couldn't get anything except a few case reports. One was published in the Indian Journal of Anesthesia. But what is very nice is the Journal of Obstetric Anesthesia and Critical Care, which is the first journal of the Association of Obstetric Anesthetists of India. Their very first issue is out, and you see that there is a review article on peripartum cardiomyopathy. There is one article about management of hypertrophic obstructive cardiomyopathy, and another one where there are 2 patients with peripartum cardiomyopathy. The management case reports are there. So I please request you all to go through the journal and read these. These are very nice articles. The most important thing about a cardiomyopathy is, the only thing which you have to remember in mind is that there is an LV dysfunction. This dysfunction could either be a systolic dysfunction or a diastolic dysfunction, depending on the type of cardiomyopathy. The systolic dysfunction is seen with dilated cardiomyopathy, peripartum cardiomyopathy, and left ventricular non-compaction cardiomyopathy, whereas the diastolic dysfunction is seen with hypertrophic obstructive cardiomyopathy and restrictive cardiomyopathies. And mortality in cardiomyopathy is only because of 3 reasons. It's either because of a cardiac failure, or it's because of arrhythmias, or it's because of thromboembolism. And if we can manage and prevent these complications, these patients wouldn't be dying. Now, already Dr. Chan has pointed out that pregnancy as such, a parturient with a cardiomyopathy, what are all the physiological changes? We know there is an increased blood volume, there is an increased cardiac output, increased stroke volume. So what is the relevance to us as anesthesiologists? First of all, an ordinarily pregnant woman itself can have symptoms of mild breathlessness. She could have pedal edema, some amount of fluid retention, a little fatigue and dizziness. So if she's going to be in grade 1 heart failure, we might actually miss the cardiomyopathy. We've had 2 cases in our own institute where we only diagnosed the peripartum cardiomyopathy after giving the spinal anesthesia on table, and then found out that the patient had very severe hypotension. Then we resuscitated her, we did an echo in the post-anesthesia care unit and found that the ejection fraction was only 35%. It was not severe enough to present as symptoms, but once the spinal was given, she had very severe hypotension. So what you have to remember is mild cases of cardiomyopathy with systolic dysfunction. The patients who are in NYHA stage A heart failure, you might not pick up because the pregnancy symptoms might mask the symptoms of heart failure. And the second event, of course, is the clinical deterioration. Many cardiomyopathies, because of this volume overload of pregnancy, there tends to be a clinical deterioration of the cardiac function during pregnancy. In addition to this, labor, we know, is associated with intense sympathetic stimulation, and of course there is the autotransfusion of uterine contraction following delivery, and all this can result in clinical deterioration. This we should remember. The other issue, as Dr. Chan and Dr. Rizvi had pointed out, in a parturient with cardiomyopathy is, we know pregnancy as such is a procoagulable state. And now you have a pregnant woman who has heart failure where there is venous stasis, and then she has arrhythmias because of cardiomyopathy, then the stage is set for a very high risk of thromboembolism. So this is another reason why patients with cardiomyopathy have mortality. And the third thing we have to remember is these patients are going to be on medications. Many of them are for heart failure. Many of them are for treating the thromboembolism or for the arrhythmias. So we have to know what is the FDA safety classification of cardiovascular drugs to be used in pregnancy. Now I'm just talking about peripartum cardiomyopathy as an example of systolic dysfunction and hypertrophic cardiomyopathy as an example of diastolic dysfunction. If you look at peripartum cardiomyopathy, the definition as per the National Heart, Lung and Blood Institute and the Office of the Rare Diseases is, they have traditional criteria where the heart failure develops only in the last month of pregnancy or in the first 5 months postpartum. So there's a timeline. It's in the last month of pregnancy or the first 5 months postpartum. In the absence of identifiable cause of heart failure, there is no other reason, there's no other structural heart disease as a result of which she's having a cardiac failure, and the absence of recognizable heart disease prior to the pregnancy. In addition, they've added echocardiographic criteria where the left ventricular ejection fraction has to be less than 45%, the fractional shortening has to be less than 30%, and the end diastolic dimension of the LV should be more than 2.7 centimeter per meter squared. So basically, peripartum cardiomyopathy is a diagnosis of exclusion. Now a new definition has come up from the working group on peripartum cardiomyopathy from the European Society of Cardiology. How they've changed it is what I've marked in yellow. Basically, they've removed the timeline. They say don't say last month and don't say 5 months postpartum. Just say towards the end of pregnancy or in the months following delivery. That way you wouldn't be missing the cases which present a little early or a little late. And another thing which they say is the LV need not always be dilated in a peripartum cardiomyopathy. So that is the difference in the new definition which has come from the European Society of Cardiology. Now basically, if you look at the pathophysiology, is PPCM a variant of dilated cardiomyopathy? No, because in peripartum cardiomyopathy, you have symptoms coming only in the third trimester, and most of the patients recover after the delivery. It might take 5 months, it might take up to 12 months, but they generally recover. Whereas in dilated cardiomyopathy, patients present with cardiac failure in the second trimester of pregnancy, which is the period of maximal hemodynamic stress, and they do not recover their LV function at all. So it's no longer, peripartum cardiomyopathy is not a variant of dilated cardiomyopathy. It's a separate entity of its own, the cause of which is not known, and just like any other disease for which we do not know the cause, we come up with several theories. It could be probably a myocarditis, it could be an abnormal immune response, or it could be because of excessive prolactin production. We do not know what's causing it. But in general, the end result of whatever is happening is a global decrease in myocardial contractility, which is going to result in symptoms and signs of cardiac failure. I'm not going to elaborate on this because we're all very familiar as to what the symptoms and signs of systolic cardiac failure are. Now coming to the investigations, ECG is unremarkable in a patient with peripartum cardiomyopathy. The patient can have left ventricular hypertrophy, she can have ST wave changes, she can have arrhythmias. But one thing which has come up is, there is one case report where a new onset of a left bundle branch block turned out to be an imminent sign of a peripartum cardiomyopathy. So if you have a new onset left bundle branch block, just that should put on a red flag. Echo is the diagnostic modality where it will show a 4-chamber enlargement with a marked reduction in ejection fraction with pericardial effusion and of course valvular regurgitation. And other diagnostic modalities include BNP and end-terminal pro-BNP. Whenever there is going to be a volume or pressure overload of the heart, so the BNP levels tend to go up. So they can help us find out which of the patients who have cardiomyopathy and cardiac failure. A cardiac MRI can also be done. That's a useful diagnostic modality. And basically, management of these patients, as Dr. Rizvi pointed out, is not a one-man's job. It has to be a multidisciplinary team with the obstetrics, cardiologists, and anesthetists working in a very coordinated fashion. How do we prepare these patients for cesarean section? Basically, you have to manage the heart failure by 3 ways. We have to decrease the volume overload, control the afterload, and increase the myocardial contractility. To decrease the volume overload, in addition to fluid and salt restriction, we know diuretics are used. One word about the diuretics, what is safe in pregnancy is furosemide and hydrochlorothiazide. Spironolactone is not given during pregnancy because of its anti-androgenic effects. Second thing is to control the afterload. Vasodilators can be used in peripartum cardiomyopathy. The commonly used ones are nitroglycerin and hydralazine. They are quite safe during pregnancy. For short term, you can use sodium nitroprusside, but remember there is a risk of cyanide toxicity, so it is important to monitor cyanide levels if you're using sodium nitroprusside. The other group of drugs commonly used to reduce the afterload are the beta blockers. Regarding the beta blockers, usually atenolol is the one which is not used because it has been shown to have a very high incidence of intrauterine growth retardation. The other drugs like metoprolol or carvedilol can be given. And there are studies which have shown that beta-1 agonists are probably better than beta-1 blockers are better than beta-2 blockers because you don't have the tocolytic effect then. AC inhibitors and angiotensin receptor blockers are not advisable in pregnancy. They are contraindicated, but they can be used for managing the postpartum period. Regarding increasing myocardial contractility, digoxin is a very good drug. And for acute control, we can use any of the inotropes, the catecholamines, the phosphodiesterase 3 inhibitors, or even levosimendan. Regarding levosimendan, it's one of the newer drugs which has been used for treating. There are 3 published case reports where levosimendan has been used in the management of patients with peripartum cardiomyopathy. The main advantage is that it helps in myocardial contraction without increasing the oxygen cost because it doesn't increase the myocardial calcium levels but just sensitizes the contractile elements to the calcium. So it's one of the very good drugs, and if it's not responding to the usual inotropes and phosphodiesterase inhibitors, please do remember levosimendan, which comes like this as a yellow lyophilized powder and has to be given as an infusion. The next important point, of course, is antithrombotic therapy. As Dr. Chan and Dr. Rizvi had pointed out, we have 3 options: vitamin K antagonists, unfractionated heparin, and low molecular weight heparin. Vitamin K antagonists are usually not given in the first trimester because there is a very high risk of embryopathy and there is also the risk of fetal bleeding. Unfractionated heparin cannot be given for a long time because of the issues with thrombocytopenia and osteoporosis. So low molecular weight heparin is a good choice. Some of these patients could also be on cardioverter defibrillator because they are more prone for arrhythmias, and some could be on cardiac resynchronization therapy, which means in a normal, you just usually have in a pacemaker a right atrial and a right ventricular electrode. In these patients in cardiac resynchronization therapy, you have an additional electrode which is passed through the coronary sinus into the left ventricle. This is just to make sure the left ventricular and right ventricular contractions are more synchronized, and that helps in increasing the cardiac output. So it's called cardiac synchronization therapy, and this is recommended to coordinate contraction of both ventricles when you have class 3 and class 4 symptoms in patients despite optimal therapy associated with a QRS duration of more than 120 milliseconds, then this is done. And another newer therapeutic strategy is because of cardiomyopathy, peripartum cardiomyopathy is believed to be because of excessive prolactin production. So this is a study done from Cape Town by Karen Silva et al., where they've shown that using bromocriptine, which causes dopamine receptor agonism and suppresses prolactin production, decreases the incidence of complications. And compared to placebo, the outcome was much better in these group of patients who received bromocriptine. The other options, of course, are LV assist devices, cardiac transplantation, and there is one report where they've used extracorporeal membrane oxygenation to get the patient out. Now, what about anesthetic management? Pre-medication, these patients will be on anticoagulants. So as per the ASRA guidelines, you'll have to stop the anticoagulants prior to elective surgery, continue the cardiac medications and anti-aspiration prophylaxis. The most important thing is don't forget to check serum electrolytes because most of these patients are on furosemide, which tends to bring the potassium level down, and you don't want digoxin toxicity because they are also on digoxin most of the time. So potassium and magnesium levels have to be checked. Anesthetic management, remember the cardiac grid. We have to take care of the preload, the afterload, the heart rate, and the myocardial contractility. We have to maintain the preload and avoid any increase in afterload. It's already a failing heart. You don't want to increase the resistance to its pumping, and avoid an increase in the heart rate, and similarly avoid depression of myocardial contractility. So that's quite a tall order. So options are regional anesthesia, general anesthesia. The main advantage of regional anesthesia is that it decreases the afterload, which is going to help a failing heart. and general anesthesia we know is associated with a lot of hemodynamic stress which a decompensated heart might not be able to take. Most of the inhalational anesthetics are myocardial depressants, and in general there are a lot of issues of GA and a parturient. So we choose general anesthesia for a cardiomyopathy in a patient only if it's an emergency cesarean, or the patient is on anticoagulants and we cannot give a neuraxial block, or the patient has got class 3 and class 4 symptoms and is in pulmonary edema where mechanical ventilation is going to help. The choice of regional anesthesia is, of course, a single shot spinal, continuous spinal, combined spinal epidural, and an epidural. Single shot spinal is not advocated. It's not appropriate in a patient who's got a cardiomyopathy because there can be sudden hypotension. It's quite dangerous, and we can't even, not that preloading or co-loading might help, but we can't even give that amount of fluid because of the risk of pushing them into pulmonary edema. Continuous spinal, microcatheters are no longer available. I think the FDA has removed them because of the high incidence of PDPH and Cauda-Equina syndrome. But there is a report by Dressner et al. They have actually done on 34 patients with different types of cardiac diseases. They've done using 24-gauge spinal catheters. 4 of their patients actually had peripartum cardiomyopathy. They were giving 0.25 ml of 0.5% hyperbaric bupivacaine and incremental doses, and they found the outcome was quite good. And they say the advantages are there is more hemodynamic stability, it's much more rapidly and effectively titrated, and the failure rate is much lower compared to an epidural. Combined spinal epidural is, of course, another technique where you just give a very small dose of local anesthetic along with the narcotic intrathecally and then maintain it with a graded epidural. Or, of course, we can go to our good old epidural and give it in graded doses. The most important thing, whatever technique is chosen, is that you have to treat hypotension, and you do not wait for the normal 30% fall from the baseline values in these patients. Even a 10% deviation from the values has to be attended to. And the drug of choice is, of course, phenylephrine because it avoids tachycardia, and as such it maintains the fetal oxygen supply demands balance much more. Intraoperative maintenance, remember that rushing IV fluids into these patients can again push them into pulmonary edema, so judicious titration of intravenous fluids has to be done. And we said auto transfusion is going to increase the blood volume. So just before delivery, you'll have to give a dose of diuretic to these patients. And you might also need inotropes and vasodilators loaded and on board, so to use at any time. And don't forget thromboprophylaxis, so always use pneumatic compression devices. Regarding general anesthesia, an opioid-based technique is preferable because it prevents the myocardial depression with inhalational anesthetics. The ideal choice would be to use remifentanil with some amount of etomidate. We do not have remifentanil, but we can still use fentanyl with etomidate. That you can still maintain cardiovascular stability. And as Dr. Chan pointed out, remember to inform your neonatologist that you've given opioids because they have to be ready for mechanical ventilation and with naloxone. And the advantage of GA is it helps us to use transesophageal echocardiography to see, especially in patients who are also having pulmonary hypertension or mitral regurgitation, the central venous pressure might not give a good reflection. So TEE will be a very useful tool at that time to see the LV. Monitoring, regular monitoring. In addition, I would suggest it's always better to use invasive arterial blood pressure monitoring in all these patients because we said we don't even want to have more than 10% hemodynamic disturbances, and a central venous pressure monitoring to judiciously give fluids. In NYHA 3 and 4 patients, it's probably prudent to add PA catheters, cardiac output, invasive or non-invasive, and transesophageal echocardiography. Regarding uterotonics, we know oxytocin is going to cause hypotension and tachycardia, and we do not want both these for the cardiomyopathy patients. So it's very important to give slow infusions of oxytocin only and not give bolus doses. There is an article where ultra low doses, 0.05 international units have been used, and they've shown that there is no hypotension, but I've never used boluses of oxytocin. And another good idea would be to co-administer oxytocin with phenylephrine, especially because in these patients, ergometrin and prostaglandins are contraindicated. So oxytocin is the only drug which you can use, and you do not want any hypovolemia and because of uterine atony. So co-administering oxytocin with phenylephrine will decrease the... How long do I have?
1 minute.
1 minute, okay. So post-operative care, continue care in the ICU, continue cardiac medications and anticoagulants. And post-operative analgesia, if you've given an epidural, you can continue it, or a TAP block can also be used in patients who had a general anesthesia, and continue all the care which you gave in the intraoperative period on to the post-operative period as well. Now just 2 more slides about hypertrophic obstructive cardiomyopathy. That's a classic example where you have a diastolic heart failure. Basically, there is an outflow obstruction and mitral regurgitation. Most of these patients, in addition to arrhythmias, they are also prone for myocardial ischemia because of the left ventricular hypertrophy, and mostly they are on beta blockers and calcium channel blockers. These patients would also be requiring infective endocarditis prophylaxis. So the cardiac grid in these patients is keep the heart rate low, keep the myocardial contractility low, avoid any decrease in the afterload. So a GA is quite ideal in a patient with hypertrophic obstructive cardiomyopathy, though there are case reports of using titrated epidurals and combined spinal epidurals, but do not use ephedrine, do not use inotropes, do not use vasodilators. Keep IV beta blockers always ready, and be very aggressive with postpartum bleeding because they do not tolerate hypovolemia. And for this condition, ergometrin is a good choice as a uterotonic. And same principles for postoperative care as for intraoperative. So take-home points: cardiomyopathy are a rare but fatal diseases. It's important to understand the pathophysiology of each type of cardiomyopathy, otherwise we will not be able to deliver good anesthetic care perioperatively. And basically it requires multidisciplinary coordination. And what's most important is more than the technique, as Dr. Rizvi pointed out, strict hemodynamic control and meticulous cardiovascular monitoring are more important than any specific drug or any specific technique. Thank you.